How's it going, class? This is going to be our week 12 lecture on substance use disorders. So make sure you have your slides downloaded, you have your notes ready, and you're good to go. So let's get started by talking about drugs of abuse, also referred to as psychoactive substances. So psychoactive substances alter your mood, your mental ability, or your behaviors. Now, these are commonly referred to as drugs. So these can be both legal and illegal drugs. So for example, you could have prescription drugs, you could have over-the-counter drugs like caffeine or nicotine, and then you could also have illegal drugs or Schedule One drugs like cocaine, LSD, heroin, things of that nature. Now, just because somebody has issues with using drugs doesn't necessarily mean that they have a substance use disorder. So it's more than just using drugs or having issues with drugs. You need to have a variety of things occurring at the same time. So a substance use disorder is going to be a problematic pattern of substance use leading to clinically significant impairment or distress. This is going to be manifested or needs to be manifested by at least 2 out of 11 symptoms that fall into the following categories. We have impaired control, social impairment, risky use, and tolerance withdrawal. So we're going to talk about each one of these categories in depth later on their own slides. But keep in mind that these symptoms are going to be the same. The requirement of these symptoms are going to be the same across all substance use disorders. So we also have a specifier when it comes to substance use disorders, and the specifier is based on the number of symptoms that are met. So for example, mild would be 2 to 3 symptoms, moderate is going to be the presence of 4 to 5 symptoms, and severe is going to be the presence of 6 or more symptoms. Before we move on, let's go ahead and go over some quick review. So what is a psychoactive substance? Is it any illegal drug? Any non-prescription legal or illegal drugs? Something that alters cognition, mood, or behavior? Drugs other than alcohol? E, none of the above. The answer is C, something that alters cognition, mood, or behavior. Okay, so there's going to be 4 symptoms that fall under the impaired control category. So first, the substance is often taken in larger amounts or over a longer period than it was intended. So for example, this is going to be somebody that might say, hey, I'm just going to have a couple of drinks just to try to relax. But then it spirals and it turns into a big, heavy drinking episode, and I'm binging and I'm, drinking a lot of different things. So this is going to be something where the quantity is greater than my current intention, or the duration of my usage is greater than my intended duration. So another possible symptom is the persistent desire or unsuccessful efforts to cut down or control substance use. What does that mean? That means I have a desire to cut down on using, but I keep failing to do so. And then this is like, I've actually attempted to cut down and I failed to maintain these goals. So somebody might say, okay, I need to stop doing this, but then I'll do it anyways. You know, you might say like, I want to quit, but my actions show otherwise. It's one of those things that happens. So next, there might be a great deal of time spent in activities necessary to obtain the substance, use the substance, or recover from its effects. So for example, the person might spend a great deal of time not only attempting to get the substance, but they might spend a significant amount of time using the substance or recovering from the intoxication or high at the expense of other activities. So this might be somebody using a lot of or spending a lot of time trying to gain money to buy drugs. Maybe the process of using drugs itself is very time consuming. Like you have to cook it up or you have to prepare it for usage. Or maybe the after effects are pretty severe. So for example, if I'm waking up at 2 in the afternoon every day because I'm always hungover, or if I'm feeling dope sick for a few days after a bender, this could be this could be an example of impaired control. And then the last symptom here for impaired control would be the person might have a craving or a strong desire or urge to use the substance. So we'll talk about this a little more later, but the craving involves classical conditioning and is associated with specific reward structures in the brain. So a person will learn to associate situations and outcomes with the use of a substance. So now we have the social impairment category. So there are 3 symptoms that fall into the social impairment category. This is going to be starting with a symptom that recurrent substance use results in a failure to fulfill major role obligations at work, school, or home. So, for example, a person might regularly miss work or school due to being intoxicated or hungover from the effects of a substance. They might do bad at a job at work or school. They might fail courses. They might get in trouble at work. They might regularly neglect their responsibilities at home due to substance use. Next symptom is going to be continued use of substance despite having persistent or recurring social or interpersonal problems caused by or exacerbated by the effects of alcohol or the whatever substance they're using. So, for example, a person might engage in physical alterations when high or intoxicated, or regularly get into arguments with others about what happens under the influence of the substance. And finally, important social, occupational, or recreational activities are given up or reduced because of drug use. So, this is where somebody might have been really into gymnastics or hiking or things like that. And then once they become addicted, or once they have these, start to develop the substance use issue, they're no longer doing those things. So, this might seem like somebody who's just this is a little bit different from anhedonia. This is not somebody who used to enjoy something and no longer enjoys it. This is somebody who is willfully given up activities to pursue drug use. Now we have two symptoms in the risky use category. So first, the person might engage in recurrent substance use in situations where it is dangerous to do so. This would be like driving while drunk. This could be using in like a dope house. This could be engaging in risky activities. The substance use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that's likely to have been caused or exacerbated by the substance. This could be mood changes or physical conditions. So, for example, someone might drink even when the individual knows is bad for the liver problems. I have had situations where individuals have cirrhosis of the liver and they are still compelled to drink even though they know that the drinking is what causes cirrhosis in the first place. You have individuals who may have high blood pressure, hypertension, or heart issues, but they're still using uppers, they're still taking drugs because that's that addictive quality. So now we have the last category, and this is going to be tolerance and withdrawal. So tolerance is going to be defined as either a need for markedly increased amounts, an increased dose of the substance to achieve the same level of intoxication or the desired effect compared to the initial use of the substance. And this could also be a markedly diminished effect when continued use of the same amount or dose of the substance. So, with repeated use of a substance, the nervous system becomes less sensitive to the physiological effects of that substance over time. That means more use of the substance is required in order to obtain the same level of intoxication. So, for example, you now need to drink 4 beers in order to get the same high you used to get from drinking 2 beers. Now, understand that the subjective feeling of intoxication is different from objective impairment. So, just because you feel less intoxicated doesn't mean that you are less impaired. So when I started drinking, I would drink a couple of beers and then I would pass out. Then later on, I was drinking whole bottles of Jack Daniels. Now, my level of intoxication, right, was lower, but my level of impairment, which was much higher because there was a physiological or I should say pharmacological changes occurring in my body based on the amount of alcohol that I consumed. So some drugs are more likely than others to produce a buildup of tolerance. So we see the most substantial effects among heavy users of opioids and stimulants such as cocaine. There's also unclear evidence regarding tolerance effects of marijuana. So most people who use these drugs are unaware of tolerance effects, even though some tolerance effects have been demonstrated. So now let's move down to withdrawal. So withdrawal is another indicator of physiological dependence. So this is going to be a set of symptoms where a person experiences when drug users have stopped or decreased. Now, the specific symptoms of withdrawal depends on the substance that's being used. So, for example, withdrawal symptoms for nicotine include irritability, jitteriness, muscle tremors, insomnia, and nausea. Now, withdrawal symptoms for alcohol and the most severe cases include convulsions, hallucinations, and possibly alcohol withdrawal delirium. So, this would be a confused state in which the person becomes less aware of their surroundings and has difficulties sustaining attention. So, this is typically not seen with cannabis or hallucinogens, but research is still being conducted. Marta has been presenting with signs of alcohol use disorder over the past year. She has made several unsuccessful attempts to quit because she craves alcohol in between the times she is drinking. She indicated that whereas she could get drunk on three glasses of wine when she first started drinking, she now needs to drink a full bottle of wine and take at least 2 shots of vodka to get the same effect. Which indicators of physiological dependence is Marta clearly displaying? Is it going to be tolerance, withdrawal, or tolerance and withdrawal? The answer is A, tolerance. Martha has been displaying tolerance. Now, some people might say, but Walter, what about withdrawal? She's craving. Well, withdrawal and craving are not exactly the same thing. So, tolerance is displayed here because it takes more to get drunk than it used to, right? So she has to drink more now in order to achieve the same effect. But withdrawal really isn't being displayed here because she's not exhibiting any physiological symptoms of needing to drink again. So she's not experiencing any detoxification, any shakes, or anything like that. So craving and withdrawal are going to be two separate things. So the two criteria of withdrawal and dependence, these characterize physiological dependence. So this figure right here is going to depict how tolerance occurs. So in the use of cocaine, psychoactive substances bind to the dopamine transmitters, so they can't be reabsorbed by the sending neuron, so reuptake can occur. So similar to how some antidepressants prevent the reuptake of serotonin, so that there is excess serotonin in your system, these psychoactive substances prevent the reuptake of dopamine, so that there is excess dopamine in your system. So your body is going to try to counterbalance this effect, which is going to result in tolerance. And pretty soon, you're going to need more of the drug in order to achieve the same effect. So your body is going to try to adapt to the higher dose. And if you stop taking the drug at a later time, your body, which has developed a tolerance, is going to experience withdrawal effects. So tolerance and withdrawal are not required for a diagnosis of substance use. So not requiring tolerance or withdrawal for diagnoses broadens the number of people who might meet criteria for substance use disorders. All right, so how does cocaine interact with the brain? A, it causes more dopamine to be created by the neuron. B, it blocks the reabsorption, reuptake of dopamine. C, prevents dopamine from ever entering the synapse. The answer is B, it blocks the reabsorption or reuptake of dopamine. Here's a more review for you. So Martin's friends often complain about his aggressive tendencies when he is drunk. That is, he is often starting verbal arguments with strangers that almost escalate to physical altercations before his friends intervene. Martin is continuously informed of his behaviors. It does not change his drinking patterns. What symptom category for substance use disorders does this symptom fall under? Is this going to be impaired control, social impairment, risky use, tolerance withdrawal, or ideas of reference? The answer is B, social impairment. So Lucy frequently drinks alcohol. She reported several times in the last year in which she has unintentionally ended up drinking substantially larger amounts than originally intended, over a longer period of time. She said that she often tried to stop or decrease her alcohol use, but has been unable to because she finds herself craving a drink during times when she is not drinking. Her drinking behavior has begun to affect her life negatively. Would we give Lucy a diagnosis of alcohol use disorder based on this information? A, yes, she meets at least 2 criteria and is experiencing distress. Yes, she meets at least 2 criteria, one of which is withdrawal. No, because she does not meet criteria in at least 2 symptom domains. No, because she does not demonstrate any evidence of physiological dependence. The answer is A, yes, she meets at least 2 criteria and is experiencing distress. So right over here, this is a chart showing the first specific drug associated with the initiation of illicit drug use. So right over here, we have things like marijuana, pain relievers, inhalants, tranquilizers, stimulants, hallucinogens, sedatives, and cocaines. And so right here, we see that marijuana, this according back in 2013, so these figures might have changed. So marijuana usage was like, so 70% of people, their first use of drug was marijuana. So this doesn't include things like tobacco. This doesn't include things like caffeine. These are just illicit drugs. And of course, in some jurisdictions, marijuana is no longer an illicit drug, but it's still a Schedule One drug on the federal level, which is a whole nother conversation to have. So right over here, we have a chart talking about the percentage of people that have tried the following drugs. So right over here, you can see that 75% of the population has tried tobacco. Alcohol, 91.5% of the population has tried alcohol. Then we have cannabis, cocaine, amphetamines, sedatives, hallucinogens, and heroin. As you notice here, caffeine isn't on the list. It is a substance, but that's another conversation to have. But right here, we see that the most frequently are the most used. I shouldn't say most frequently, but most people have used tobacco, alcohol, or cannabis at some point in their life. So right over here, this is substance use in the past 30 days. So you'll see right here, we have cigarettes, 31.8%, alcohol, 60.2%, marijuana, 18.7%, cocaine, ecstasy, LSD, inhalants, and opioids at a lower percentage rate. This is based off a population in America. So as you can see right here, alcohol is commonly used, but some of the other drugs not so much. Once again, this is from 2013, so these numbers might have changed based on the legality of marijuana usage. And also, these are all from self-report measures, so the person has to self-disclose their usage, which could also explain some of the lower numbers. And this was what people think the most addictive drug is. So, based on self report, people believe that tobacco is the most addictive substance, followed by heroin. Then we go down to cocaine, alcohol, amphetamines, sedatives, cannabis, and hallucinogens. Now, this is not based off any scientific evidence or physiological evidence, anything like that. This is just based off what individuals report as being the most addictive substance, or what they think the most addictive substance is. So when we're looking at these numbers, there could be a variety of explanations of why this is. So, for example, some people um, might view that some of these drugs are more socially acceptable than others. So it might be, so people might feel like, oh, well, um, some of these like alcohol, tobacco, it's very, it's very socially acceptable to, smoke tobacco or use tobacco, I should say, and then drink alcohol. That it's very socially acceptable. So these are just drugs that people are okay with you using. But things like heroin and cocaine, these could be more physically addicting and have greater withdrawal symptoms. So this is why people are addicted to these. And so there's a variety of different explanations: legal versus illegal, physiological versus psychological. There's a bunch of different differences of why this might be, but it depends on the person and what they view about these drugs. Right over here, we have some numbers from 2018. This is basically UIUC students' substance use statistics. So right over here, we have some alcohol in the past year, so like 67.8% of students UIUC students drink alcohol in the past year. Now, the reference group was other college students at different universities. The rate of drinking there was 65.1%. So that's like an average across all the universities. So we were a little bit above that. So we have the binge drinking. So these are 46.5% of students. So what this means that within the previous 2 weeks, these individuals had consumed 5 or more drinks within one sitting. Then we have heavy and frequent drinkers. So heavy drinkers are going to be people who consume 5 or more drinks in a single sitting, 3 times per week or more. And so mostly the individuals who responded to the survey used with friends and consider drinking a leisure activity. So we have some information here also about social norms. So social norming theory suggests that if students perceive a culture of drug use and the students identify with the cultural element, they're more likely to participate in the behavior. So there are actually discrepancies between student behaviors and their perceptions of average student behaviors. So some of the programming goals for people to do for interventions or to harm reduction programs is to try to allow students to know these discrepancies. So for example, 85% of students believe that the average student on campus uses alcohol once a week or more. But in fact, only 47.5% of students actually report using alcohol once per week or more. Once or more per week, I should say. 71.8% of students believe the average student on campus smokes weed or uses marijuana once a week or more. But in fact, only 18.6% of students actually report using marijuana one or more times per week. And once again, these are from 2018. So in 2018, 50% of students had reported the use of an illegal drug or an illicit substance. So 36.3% of students reported using marijuana within the past year. About 14.3% of students reported using an illegal drug other than marijuana in the past year. So then, apart from marijuana usage, some of the 30-day usage was 3.2% cocaine, 2.3% hallucinogens, 1.3% designer drugs, is like ecstasy and the MDMA, 1.2% amphetamines, methamphetamines. So when it comes to marijuana usage, it's still illegal on the federal level. So what that means is on campus, it is still an illegal substance. That's because of federal funding. We cannot permit the usage of or the smoking or using marijuana on campus because it's still a federally illegal drug. So this is why, even though here in town, or if you're in town or in Illinois, let's just say, it is legal to smoke weed recreationally, you still can't smoke weed recreationally on campus. Now, the prevalence of alcohol use disorder does have differences depending on which groups we're looking at. So, for example, if we look at younger individuals, we see a higher rate of substance use disorders, or just say alcohol use disorders, among ages 18 to 29, and we have a lowest rate for individuals 65 and older. We have some sex differences. So males are 5 times more likely to chronically abuse alcohol than females, and this might be due to socialization and other factors. We have racial and ethnic differences, and so this could be due to socioeconomic status or different racial stressors that that are prevalent in different ethnic groups. So now, before we get into talking about alcohol use disorders, here's a little video here talking about alcohol use disorder symptoms. Also, make sure you're reading the DSM-5 for the criteria for alcohol use disorder. And make sure you also go there and look up the other disorders that we'll talk about during this lecture.
Alcohol is one of the most widely used psychoactive substances in the world, and it's been a part of different cultures for hundreds of years. Drinking alcohol can have serious harmful consequences. It's been linked to various cancers, gastrointestinal diseases, as well as metabolic problems. Over time, regular use of alcohol can lead to alcohol dependence and bouts of withdrawal, and this can take a serious physical and emotional toll on a person's life. Alcoholic drinks contain the chemical ethanol, which is a tiny molecule that reduces the activity of various inhibitory and excitatory neurotransmitter pathways in the brain. Inhibitory neurotransmitters make neurons in the central nervous system less likely to fire an action potential. And the brain's major inhibitory neurotransmitter, gamma aminobutyric acid, or GABA, acts as an off switch and restricts brain activity. Ethanol is a GABA agonist, so when it binds to GABA receptors, it makes the inhibitory signal even stronger. Ethanol also activates opioid receptors and induces the release of endogenous morphine, known as endorphins. The opioids then bind to receptors on the dopaminergic neurons in the nucleus accumbens, which trigger the release of dopamine and serotonin in that part of the brain. Ethanol also acts as a glutamate antagonist. In other words, ethanol blocks glutamate, which is an excitatory neurotransmitter, from binding to glutamate receptors, making it less likely that those neurons will fire. The combined effect that ethanol has on these neurotransmitters varies by the location in the brain. For example, in the nucleus accumbens and the amygdala, which are the reward centers of the brain, ethanol produces pleasant or rewarding feelings like euphoria. This is important because if a person believes that drinking leads to euphoria, they're more likely to drink again. In the cerebral cortex, the thought processing center of the brain, ethanol slows everything down. making it difficult to think and speak clearly. Ethanol also slows behavioral inhibition centers like the prefrontal cortex, making people feel more relaxed and less self-conscious. In the cerebellum, the area responsible for movement and balance, ethanol causes individuals to lose their coordination, making it harder to walk or do complex tasks like driving. Ethanol also affects the hypothalamus and pituitary glands, which regulate various hormones and mood. In these areas, ethanol typically increases sexual arousal, but decreases a person's ability to engage in sex. In the medulla, which controls automatic functions like breathing, consciousness, and body temperature, ethanol increases sleepiness, slows breathing, and lowers the body's temperature to a point where it's life-threatening. Alcoholic drinks have varying amounts of ethanol. For example, 355 milliliters, or 12 fluid ounces of beer, typically has 5% ethanol by volume. 148 milliliters, or 5 fluid ounces of wine, has 12% ethanol by volume. And 44 milliliters, or 1.5 fluid ounces of 80 proof distilled spirits like gin, rum, tequila, or whiskey has 40% ethanol by volume. All three of these alcoholic drinks therefore have about 18 milliliters of pure ethanol. Ethanol's effects on a person are directly related to the blood alcohol content, or BAC, which is the percentage of ethanol in a given volume of blood. BAC is affected by the amount of ethanol consumed, as well as a person's blood volume, which depends on their size and sex, as well as situational factors like how much they've had to eat or drink, what other substances or medications they might be using, and how well the body's prepared for the alcohol. At a blood alcohol content of 0 to 0.05%, people typically feel relaxed and happy, but might have slurred speech, and some difficulty with coordination and balance. At a blood alcohol content of 0.06 to 0.15%, there's more impairment in speech, memory, attention, and coordination, and some individuals can get aggressive and even violent. Complex tasks like driving can become dangerous, which is why it's illegal to drive in some countries with a blood alcohol content of 0.08% or higher. At a blood alcohol content of 0.16 to 0.30%, individuals can experience alcohol poisoning, with blackouts or periods of amnesia, vomiting, or even a loss of consciousness. Finally, at a blood alcohol content above 0.31%, the effect of alcohol can severely suppress breathing and even lead to death. Over time, individuals who consistently use alcohol can develop tolerance to its effects. This means that with repeated use, they have a reduced response to alcohol, and therefore an increased dose is needed to achieve the original response. At a cellular level, there are a couple theories that explain why this might happen. One is that repeated exposure to ethanol might cause GABA, glutamate, dopamine, and serotonin receptors to become less sensitive to alcohol. Another is that neurons might remove these receptors from the cell wall in a process called downregulation, leaving fewer receptors available for binding. In either scenario, tolerance leads to the need for higher and higher doses of alcohol, and oftentimes that tolerance stays for a long time even after decreasing alcohol use. Now, let's say you're at rest, without alcohol or anything stimulating your reward pathway. In this situation, your brain keeps your heart rate, blood pressure, and wakefulness in a normal state, called homeostasis. Now let's say that your secret crush sends you a text. All of a sudden you might feel sweaty and flushed, and your heart rate might jump a bit. You're now above your normal level of homeostasis, because something's changed, right? But it doesn't stay that way for long, and after the text, your brain brings things back down to its baseline. With repeated alcohol use, a few things start to happen. Let's say you drink at a specific time and setting, like 5 p.m. in the kitchen. And being a depressant, it makes everything go slower, including heart rate, blood pressure, and wakefulness. Your brain, being the smart brain that it is, will pick up on that pattern for next time. Now, next time at 5 p.m. in the kitchen, the brain preemptively increases functioning, since it knows that when you drink the alcohol, everything's going to decrease. Now let's say 5 p.m. in the kitchen rolls around, but there's no alcohol. In that situation, the brain still increases heart rate and blood pressure, but the changes aren't countered with the effects of the alcohol, and so the person can feel awful, and these are called withdrawal symptoms. These symptoms can persist to the point where a person might need alcohol just to feel normal, and if that's the case, they're considered to be dependent on alcohol. Now, on the flip side, let's say that you use alcohol in an unfamiliar setting, like at a party at 11 p.m. Well, in that situation, your body's not ready for the alcohol, and there's no physiologic counterbalance to help offset the effect of the alcohol. When that's the case, it can lead to an overdose, even on a dose or amount that the person's been normally taking. And that's oftentimes what happens. Symptoms of alcohol withdrawal can include anxiety, depression, irritability, fatigue, tremors, palpitations, clammy skin, dilated pupils, sweating, headaches, difficulty sleeping, vomiting, and even seizures. A severe complication of withdrawal, called delirium tremens, can take place a few days into the alcohol withdrawal, and include symptoms like a high fever, intense agitation, visual hallucinations, and even tactile hallucinations, where it feels like something's crawling on the skin. These symptoms are so severe that they can lead to death. So, given how awful alcohol withdrawal can be, people will sometimes continue to drink simply to avoid them, a process called negative reinforcement. Negative reinforcement, or drinking more to avoid discomfort, often combines with the positive reinforcement, or drinking more to increase feeling euphoric, and leads to alcohol addiction, or alcohol use disorder. Now, the DSM-5, or Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, defines alcohol use disorder as a maladaptive pattern of alcohol consumption that includes at least 2 of the following behaviors within the past year. 1. Consuming more alcohol than intended. 2. Being unable to cut down on alcohol use. 3. Having alcohol use take up a lot of time. 4. Having cravings to use alcohol. 5. Having alcohol use affect responsibilities. 6. Using alcohol even if it causes interpersonal problems. 7. Giving up important activities in order to use alcohol. 8. Using alcohol in physically dangerous situations, like while driving. 9. Using alcohol even if it's worsening a physical or psychological problem. 10. Becoming tolerant to the alcohol. And 11. Feeling withdrawal symptoms from alcohol. Having 2 or 3 of these symptoms is considered mild. Having 4 or 5 is considered moderate. And having 6 or more is considered severe. Even mild alcohol use disorder can be debilitating because of the negative effects it can have on a person's ability to function at work or in relationships. In addition, alcohol use disorder has serious long-term health consequences. Chronic alcohol use can damage the heart, causing dilated cardiomyopathy, where the heart muscle stretches out like a large floppy sac. This also leads to other problems like arrhythmias, or irregular heartbeats, as well as strokes. Chronic alcohol use can also cause inflammatory changes in the liver, affecting its ability to function. The complications include steatosis, hepatitis, fibrosis, and cirrhosis. Similarly, it can cause pancreatitis, inflammation of the pancreas. Alcoholism is also associated with the risk of developing certain cancers, including mouth, esophagus, throat, liver, and breast cancer. Finally, it's common to see vitamin deficiencies in those with alcohol addiction, largely thought to be due to having a poor diet. This can lead to problems like Wernicke-Korsakoff syndrome, which results from thiamine deficiency in chronic users of alcohol, and causes problems like vision changes, ataxia, which is a problem with movement and balance, and an impaired memory. Excessive alcohol use can also end a person's life in an overdose, most often due to severe cardiac and respiratory depression, to the point where a person might lose consciousness and simply stop breathing. For individuals with alcohol use disorder, the most effective treatment is a combination of individual and group therapy. For example, motivational interviewing is an individual therapy that can be used to understand why an individual wants to stop using alcohol and identify certain barriers to treatment. Cognitive behavioral therapy can help an individual learn about withdrawal, discuss the thoughts, feelings, and behaviors that lead to alcohol use, and create a plan to navigate triggers for use. In addition to individual therapies, peer support programs that use group discussions to help individuals commit to ending the use of alcohol, as well as provide a space to hold each other accountable and build up their support groups. There are also medications for alcohol dependence, including naltrexone, acamprosate, and disulfiram, which work best in conjunction with therapy. Naltrexone is a mu-opioid receptor antagonist that blocks the euphoric effects of alcohol and feelings of intoxication. This can help people with alcohol use disorder reduce heavy drinking enough so that they stay motivated to continue treatment and avoid relapse. Acamprosate can be administered immediately following acute withdrawal and reestablishes some of the GABA and glutamate pathways that are disrupted by alcohol. Finally, there's disulfiram, which works by inhibiting the enzyme acetaldehyde dehydrogenase. In the body, alcohol is converted to acetaldehyde, which is then broken down by acetaldehyde dehydrogenase. So when acetaldehyde dehydrogenase is inhibited, acetaldehyde levels build up and cause the effects of a hangover to happen immediately after alcohol is consumed, which decreases the likelihood that a person will drink alcohol again. Alright, as a quick recap, alcohol consumption affects different neurotransmitters and neural systems in the brain, which produces impairment that's initially pleasant or enjoyable, but can become more problematic and unpleasant if drinking continues. Long-term use can cause tolerance, which is the need for increasing doses to achieve the same effect, as well as dependence, which is the reliance on the alcohol to function normally. The most effective treatments can include a combination of therapy and medications, with a lot of love and support from family and friends. Thanks for watching. You can help support us by donating on Patreon.
All right, so that video right there was talking about alcohol use disorder. I would encourage you to go to the DSM-5 and look up the diagnostic criteria for alcohol use disorder. Make sure you watch the videos I have in the study folder. If you have additional questions, please come to office hours or please send me an email. So now we're going to look at the like a family history of substance use. So right over here we have 3 generations of the Barrymore family. This is a Hollywood family. So John Barrymore, which is Drew Barrymore's grandfather, was a stage actor and he was a heavy drinker. Drew Barrymore has a tense relationship with her father, John Drew Barrymore, and he was described as an alcoholic. Now, during Drew's childhood, she began acting at the age of 3. She was hosting Saturday Night Live at the age of 7. She was drinking at 9. She was using drugs, smoking marijuana at 10, cocaine at 12, and she was actually in rehab at the age of 14. So that's some examples there of like genes through her family, environment through, the Hollywood lifestyle. But now we kind of look at maybe the genes by environment. So this is another example of the diathesis stress model. So right over here, you could say that Drew Barrymore has a genetic predisposition to alcohol substance use, just based on her family history. And then when you think about how if she had not been exposed to Hollywood at such a young age, she might not have developed a disorder at all, or it might not have developed later in life. So when looking at some genetic factors here, through twin studies, researchers have found that there's a significant genetic influence for twins, for male twins as opposed to female twins. So for example, monozygotic twins, you have 56%, dizygotic twins, 33%. That's a concordance rate of substance use disorders. And then for females, monozygotic twins, we have 30%, dizygotic twins, we have 17%. So we see right here, there's almost like a 2-to-1 difference between males and females if we're looking at dizygotic and monozygotic twins. So there are some sex differences when it comes to alcohol tolerance. So females have a lower physical tolerance than males. Some people think that maybe this is because of the lower total body water in females than males. So body water dilutes alcohol, and since it's lower in females, they will feel the effects quicker, or should I say quicker. So this means that they process alcohol faster than males, so they feel the effects faster. Also, some individuals say that there are some negative social attitudes that contribute to these differences. So, alcohol use disorder might be more common in males because of socialization, where public intoxication is discouraged in females and it might be encouraged in males. So right over here, we have the Cloninger adoption study, which identified type 1 and type 2 alcoholics. So a type 1 alcoholic is an individual whose biological parent had a later onset of drinking problems. This would be after age of 25, with an absence of criminal behavior. And then type 2 alcoholics, these are where the biological parents had an early onset of drinking problems before age 25 and had undergone treatment or had the presence of antisocial criminal behavior. So with type 1 alcoholics, it's thought that the genes associated can be moderated or influenced with environmental factors, so like the socioeconomic status of the adoptive family. And with type 2 alcoholics, it was thought that the effect of the genes seem to outweigh any environmental influence. So here's a broad overview of the findings. They found that even when individuals were raised by parents without alcohol use disorder, children whose biological parents were alcoholics early in life were much more likely to abuse alcohol as adults than those whose biological parents were not alcoholics. So this is something to think about when we're talking about nature versus nurture, when people are talking about the heritability of alcohol problems. This is something that a lot of researchers look to the Cloninger adoption study. So for people with a type 1 gene, the combination of type 1 genes and a heavy drinking adoptive father significantly increased risk for alcoholism. For people without this genetic vulnerability, it didn't make much difference whether adoptive fathers were heavy drinkers or not. So right over here, we can see right here that, this gives you some idea of the gene by environment interaction taking place. So right over here for type 2 alcoholics, we see it doesn't really matter whether or not the adoptive father was a heavy drinker. Those with type 2 genes had a significantly increased risk for alcoholism. So based on this study, what can we conclude about type 1 and type 2 genetic risk for alcoholism? Alcoholism is primarily genetically determined, whether type 1 genes are present, whereas type 2 genes increase risk of alcoholism only in the presence of certain environments. B, type 1 genes increase risk of alcoholism only in the presence of certain environments, whereas alcoholism is primarily genetically determined whenever type 2 genes are present. C, alcoholism is primarily genetically determined whether type 1 or type 2 genes are present. Or D, both type 1 and type 2 genes increase risk for alcoholism only in the presence of certain. And the answer is going to be B. Type 1 genes increase the risk of alcoholism only in the presence of certain environments, whereas alcoholism is primarily genetically determined whenever type 2 genes are present. So comparing the two types of genes separately against a control, we see differences in the rates of alcoholism. For type 1, the combination of this gene and having a heavy drinking adoptive father significantly increased the risk of alcoholism in the child as an adult. And for individuals without the type 1 genetic vulnerability, it does not appear to make much of a difference on alcoholism risk, whether or not the adoptive father is a heavy drinker. Therefore, risk for alcoholism based on the presence of the type 1 gene involves a gene by environment interaction. However, for type 2, we see that regardless of the drinking habits of the adoptive father, there is a significantly increased risk for alcoholism if a child has this genetic vulnerability. This seems to suggest that alcoholism is primarily genetically influenced in an individual that has a type 2 gene. So when you see a type 1 alcoholic, type 1 alcoholism, you want to think about a gene by environment interaction. Type 2 alcoholism, you want to think about a primarily genetic effect. All right, so what kind of social conditions might increase the risk for alcohol use? Culture or religion could influence how early someone is exposed to alcohol, as well as their attitudes towards drinking. So, for example, you might have observational learning that could play a role here too. So, cultural differences exist among ethnic groups as well. There might be initial experimentation among individuals who are more rebellious, extroverted, and if their parents or peers model or encourage the use. So, for example, this is another place where observational learning can play a role. Individuals might learn this can be a way to cope with stressors or a way to appear cool or popular. You could have unpleasant emotional environments and low parental monitoring, which will increase the risk that children might affiliate with peers that use drugs. You might think of how dysfunctional family interactions might contribute to this. So you might think about also into how this is related to economic hardships. And so parents have to work a lot, kids have to be by themselves a lot, or maybe unemployment could create tension in the household. So, children might turn to friends who might be more dangerous. Not dangerous, but might put them at a greater danger of using drugs. So there's also the gateway hypothesis that has been talked about before. So the gateway hypothesis suggests that early experimentation with drugs like cigarettes and alcohol might serve as a gateway to or the first stage in a progression to use of harder drugs in adulthood, such as cocaine. So right over here, there was a study that was actually done that found that gateway drugs used in early adolescence were significantly associated with marijuana use, illegal drugs, and cocaine in older adolescents. But over time, these relationships are not consistent in adulthood. So researchers found that other factors have played a role in the uses of drugs in adulthood. So, for example, having a history of higher depressive symptoms was associated with higher frequencies of psychoactive drug use over time. And they found that the users of health services in adolescents were less likely to use drugs as they got older. So it was actually found that this gateway hypothesis was not actually correct. So relationships between early drug use and later drug use in alcohol and adulthood cannot be solely explained through the gateway hypotheses. So whenever you hear about marijuana being a gateway drug, it's really not. Marijuana just might be the first drug of use because it's easily available and it's relatively cheap. Let's talk a little bit about alcohol expectancies. So, some effects of alcohol are due to what people think it will do to their behavior. So, for example, some expectancies people have for alcohol use is the idea that it enhances social and physical pleasure, it enhances sexual performance, it improves mood, it reduces tension, and increases social assertiveness. So, these positive expectations have a stronger influence. So, parents, peers, and media may influence an adolescent's expectations of alcohol. And adolescents who experiment with alcohol may have more positive expectations, and therefore they might consume greater amounts of alcohol. So, through various types of learning, people generate expectancies of substance use. Research has found that positive expectations have a stronger influence on increased drinking than negative expectations have on decreased drinking. So if someone has those expectations that we were just talking about, then they might be more likely to engage in alcohol use despite the knowledge of negative possibilities. And so they might disregard thinking about having worse mood, blackouts, physical discomfort, all other kinds of outcomes like that. So, as is not really surprising, parents, peers, and media have this influence. And so, if you're in around individuals who who are showing that, hey, we're having a good time drinking, hey, drinking is increasing our romantic relationships, drinking is making us or giving us a lot of friends, you might you know view that alcohol could provide you with this as well, and this would increase your positive expectancies. So there are some other ways where these disorders might develop. So, for example, we have like operant conditioning and classical conditioning. So, in operant conditioning, we are thinking about outcomes that either increase or decrease behaviors. So, in the case of substance use, we are thinking about positive and negative stimuli, or what occurs after substance use is either added or removed. So, reinforcement again involves outcomes that increase the likelihood of engaging in a certain behavior, so in this case we're talking about engaging in substance use. So alcohol use might be positively reinforced because of pleasant consequences associated with it. Now, operant conditioning can also happen through negative reinforcement of drinking behaviors, whereby a person continues to engage in alcohol use because it removes a negative or aversive state. This could be like negative mood, anxiety, or withdrawal symptoms. So, in other words, the person might engage in this behavior to achieve a sense of relief or take away unpleasant hangover withdrawal effects, which typically happens with heavy drinkers. So, other cues of substance use can be environmental. So, in this regard, classical conditioning might also happen. This is where a drug is eventually associated with particular events or situations. So, in other words, there are drug cues that elicit a conditioned response or cravings through repeated pairings with drug use. So, for example, if someone has repeatedly smoked cigarettes following a meal, after being full after dinner, this might lead to a craving for a cigarette. Drug cues can also come in the form of people as well. So, for example, you have individuals who might not really use drugs, but they get around their friends they usually use drugs with, and now they have cravings to use drugs. All right, so here, right here we have the common liabilities model. So it's been found that those who develop substance abuse tend to be involved in other problematic behaviors. This could be early sexual intercourse, other kinds of delinquent behaviors like stealing. Um, there might be some underlying factors that are contributing to these problem behaviors. This could be neurological, psychological, or social factors. So these various problem behaviors are thought to stem from the same underlying factors. This is why I refer to as common liabilities. So these common liabilities would be neurological, psychological, or social factors. And so, in terms of an underlying psychological factor, impulsivity may play a role in these problematic behaviors. All right, here's some review for you. What drug seems to be the most addictive? So, in other words, which drug has the highest addiction rate among people who have ever tried that drug? Is it going to be tobacco, alcohol, cannabis, heroin, Tiger King? Okay. Ooh, congratulations, it's number A, tobacco. So remember, tobacco is a drug and it's highly addicting. So the active ingredient in tobacco that makes you addicted is going to be nicotine. You can also get this from other methods like chewing tobacco or certain vape mixtures. All right, here's some more review for you. So, blank alcoholism refers to having biological parents with a history of criminal behavior related to an early onset of drinking problems, whereas blank alcoholism refers to having biological parents who have no criminal behavior in association with a later onset of drinking problems. So, is it A, type 1, type 2, B, type 2, type 1, C, problematic, unproblematic, D, unproblematic, problematic, or E, functional, dysfunctional? All right, go ahead and make your choice. Boom! It is type 2, type 1. Now remember, uh, a few slides ago, we were talking about type 1, type 2 alcoholism. It doesn't make sense to you, go back and watch the slide. If that still doesn't make sense to you, go ahead and send me an email. Or come to office hours. Come to office hours or send me an email. All right, so let's talk about some prevention strategies. So, a lot of researchers currently are trying to identify ways of preventing individuals from developing a disorder in the first place. Once an alcohol use disorder or a substance use disorder has been developed, it's actually very hard to to achieve sobriety or harm reduction goals. It's very hard to help somebody once they've developed a substance use disorder. So this is usually why the goal is to try and prevent it in the first place. And one of the ways that people try to do this was through DARE. And I'm a living example that DARE doesn't work. And multiple studies have found that DARE is actually not effective in reducing substance use. A lot of times it exposes you to drugs before you're even aware of what drugs are. So sometimes that's really not the best thing. And yeah, drug DARE didn't work for me, and probably didn't work for you. How many of you went to DARE? I don't know. We'll see what happens. Don't do drugs, kid. Here you go. There's that slide. That last part there. So some studies actually found that it does increase substance use, but my statement still stands. Don't do drugs. So when it comes to substance use disorders, most individuals actually don't seek treatment for substance use issues. A lot of individuals suffering from substance use disorders might be self-medicating for other mental disorders. So, for example, a lot of people with depression or anxiety might use substances. You also might have people who have agoraphobia who might use substances. You might have individuals with certain personality disorders like antisocial personality disorder, borderline personality disorder that could use substances. Individuals with post-traumatic stress disorder might use substances. So a lot of times this could be self-medication. So it's very hard to get individuals to come in and seek treatment. Now, once an individual's actually started treatment, compliance is actually very low and dropout rates are very high. Now, I just want you to imagine the situation of an individual who's suffering from addiction and they're dependent on a substance, and they're put into a treatment facility in order to alleviate or ameliorate some kind of legal charges or something like that. And now they want to leave either because they're dope sick or the experience of being in recovery is aversive, which it kind of is because let's just say like this, like when you're out there using, you're living your own life, you're setting your own schedule, and now you have somebody telling you when to eat, when to sleep. You got to take these medications, you got to go to these treatments, but you can't force somebody for the most part to stay in treatment, and they're free to leave whenever they want to, and so the dropout rate is very high. Now, there are some things that are done to try to help people stay in treatment, one of the things you want to try to do is give them medications that kind of help to ease the pain that they're going through, medications that try to help them to come down from where they're on. So sometimes you hear about people who use Suboxone, or other drugs to try to help, or other medications to try to help them, to try to wean them off of certain substances. Detoxing is a process that you want to try to help an individual do when they come in for treatment. So detoxing is helping somebody deal with those physiological medical withdrawal symptoms. So this might also involve a gradually reduced dosage of whatever drug that they're on. So, for example, if you have somebody who is an alcoholic and they are alcohol dependent, so this is the point where the alcohol use has become so severe that their body now needs alcohol to function. If you remove alcohol from that individual, they can go into shock and die. So, you would often have to use intravenous alcohol administration to gradually wean them off of the alcohol until they can be stable. Antabuse is also another medication that is often prescribed. So, what Antabuse does is it provides an aversive reaction to alcohol consumption, which includes violent nausea and vomiting. This is meant to kind of like use classical conditioning to pair negative associations with drinking alcohol, and then Antabuse also blocks the processing of alcohol by the body. So if you drink a lot of alcohol, rather than feeling high or intoxicated, you'll just feel sick. Um, there's various there's various thoughts about the uses of Antabuse. Once again, Antabuse can't be forced on somebody, so they have to take the drugs in order for it to work. So if they don't take the drugs, it's not going to work. Um, Also, there's a lot of different kinds of therapy that can be done to try to help people to become averse to alcohol. So, for example, you could have aversion therapy, which diminishes the craving for alcohol by diminishing the appeal of alcohol, by highlighting and focusing on the negative aspects, the negative side effects of drinking and intoxication. Okay, so when it comes to treatment, there's two different goals. There's going to be abstinence or harm reduction. There is no right or wrong answer. So, for example, I couldn't say abstinence is great for everybody. I couldn't say harm reduction is great for everybody. Now, I am an abstinence only person. That's because I'm abstinent. So, I don't drink alcohol. I haven't had alcohol for 10 years. So, I don't consume alcohol. I don't smoke tobacco, and I don't consume recreational drugs. That's just me. So I'm an abstinent only kind of person. That's not trying to say that I am against harm reduction. That is that my sobriety was achieved through abstinence only. And so it really depends on what the best fit is for the individual. So for some people, abstinence only is more effective. So Alcoholics Anonymous has been shown to be effective, but Anonymous is not more effective than any other program. We might ask ourselves, is abstinence necessary? So people who go to AA meetings or ever 12-step facilitation models of recovery might not necessarily be abstaining, right? So is abstinence really necessary in order to reduce the issues that arise from substance use disorders? Now, there's another question that's brought up when it comes to what treatment works. So, should our treatment decisions be based on testimonials? So, this is anecdotal evidence. So, for example, I have my life story about my 10 years of being an alcoholic and then my 10 years in recovery. And so, I could use that to talk to people and try to help them. But what should we focus on? Should we focus on my testimonial or should we focus on evidence? And so that's the tension there. Now, this is not to say you need to choose one or the other. You can both use testimonials and use evidence, but sometimes people want to know what's more effective. And that's just what researchers do. Now, let's talk about harm reduction for a moment here. So, harm reduction is something where you understand somebody is going to use drugs, but you want to try to help to reduce the chances of them harming themselves or other people. So, an example of this is like a needle distribution recovery program. This is where I know that people are using heroin and I know that they are injecting heroin. So, rather than trying to shame them for using heroin or lock them up in jail. Let me make sure I give them fresh needles. So they can come to me and they can give me dirty needles and I'll give them so I can dispose of them appropriately. And then I will give them fresh needles, or they can just come to me, I'll give them fresh needles, as many as they want. You know, I'll give them disinfecting wipes and give them bandages. So, try to help reduce the harm that is caused by intravenous heroin usage. Now, there's also other programs that try to like hand out um, naloxone. This is like something where naloxone can be given to individuals who use opioids to try to help reverse the effects of an overdose, to try to like reduce brain injury. So, for example, a lot of individuals who use heroin do overdose because all heroin is of different strengths, different mixtures, if it's not mixed appropriately, can cause different concentrations. And there's a bunch of other factors that might, that play into the overdose rate. But naloxone helps to ameliorate this or prevent this by helping people who are overdosing come out of that comatose state, come out of that that depressed state, to keep them breathing, to keep oxygen flowing to the brain. That way they can get to the hospital. It's also supervised consumption facilities. So they have these in San Francisco where individuals who are addicted to certain drugs can show up to these locations and use drugs in a safe environment where they're provided with needles, water, somewhere to sit, and there's medical care nearby. And this is controversial as well, but it's better than having somebody, because it's like one of those things where somebody's going to use the drugs, right? So you can say, no, 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 don't use drugs, but they're going to use the drugs. So if they're going to use the drugs, why not have them use the drugs in a safe environment? Okay. So when we're looking at things like harm reduction, it doesn't have to be that extreme. Harm reduction can be as simple as, okay, you're drinking 8 beers, maybe cut it down to 2. You're smoking weed all the time, and maybe you should just reduce it a little bit. You're using a lot of cocaine, maybe you shouldn't. Just try to reduce the quantity that's being used to try to reduce the kind of consequences that are involved by overusage. So here's another treatment for substance use disorders called motivational interviewing. This is actually what I do for my practicum here at the university. So motivational interviewing is a method to try to target substance use, especially with alcohol use disorders, in a non-judgmental, non-confrontational, non-adversarial form of dealing with your client. So the approach what you want to try to do is increase your client's awareness of the potential problems caused, the consequences experienced, and the risk factors faced as a result of this behavior in question. And one of the ways that you do this is through the MI principles. So you have empathy. So what you want to do is you want to express empathy for the client. You want to share. You want the clients to share their understanding, or you want the clients to express to you what they're going through. Then you want to express to the client that you have an understanding of their experience and their perspective. Like you feel for them, you feel for what they're going through. Then you have like developing discrepancy. So this is a way where, as a therapist, you're going to try to guide the client to appreciate the value of changing their behaviors and try to explore any discrepancies between how the client wants to live their life versus how they're actually living their life. So, in other words, you want to try to help the client to recognize the inconsistency between their current behavior and their long-term goals, such as occupational success, having a family, health outcomes, etc. You also want to be rolling with the resistance. What this means is the therapist is going to accept the reluctance to change as like a natural process rather than a pathological process. So when it comes to rolling with resistance, if a client has ambivalence, if they feel like they want to keep using, you want to come alongside them, let them know that you understand where they're coming from. This is a natural process, and it's natural to feel two ways about something, rather than saying, this is a part of your disease, this is a part of your problem, you just need to get over it. You don't want to do that. Also, you want to support self-efficacy. So what this means is you want to guide the client to embrace their own autonomy and help them to move towards their own change goals with confidence. So what this means for you as the clinician is so for example, with my clients, I'm the Walter expert, they're the Johnny expert. And so my ideas are good for Walter, their ideas are best for Johnny. What I want to do is help Johnny to come up with the best ideas that work for Johnny's life. And it's not up to me to tell the client what to do. The client can discover what they need to do on their own. They have all the tools that they need. They have all the skills that they need. I'm just there to help them develop those goals, and also to increase their confidence through affirmations, and help them to understand that they can achieve the goals they have set out for themselves. You also want to avoid argumentation. So what this means, you really don't want to directly challenge the clients. So you don't want to say, don't you know that smoking's bad for you? Wouldn't you just want to stop smoking? Don't you know that heroin's bad? Just don't use heroin. Or, oh, your boyfriend is, your biggest barrier. Your boyfriend is your biggest, your temptation to use. So you should just dump your boyfriend. Why don't you dump your boyfriend? Why don't you leave that guy and get somebody else, or just be single for a while? So you don't want to confront or argue with your clients with motivational interviewing. You just want to be real calm, real cool, real collected, and just let them and just talk to them. All right. So that's motivational interviewing. That's what I do. I know some of you are like, oh no, how can Walter do motivational interviewing? I told you once again, well, come on, guys. So right over here, we have some other treatments that might be conducted to help individuals with substance use disorders. So we have CBT, which is cognitive behavioral training. So one of the things you're doing right here is you want to try to retrain how the individual thinks about their substance use. So you want to try to help the individual to accept that they have a substance use issues. I think you also want to try to help them to think about what the cues that cause them to use, what kind of barriers do they have in their life, like what is stopping them from being sober, or what is causing them to use, what kind of temptations do they have, what kind of triggers do they have. And then you want to try to help them to reframe those thoughts, reframe those triggers. So for example, you could say, well, every time I go to the sports bar, I want to drink because my friends are drinking. It's where I go to relax. And then you might help them to come up with other ideas of how to relax or things that they might want to do. So that's CBT, so cognitive behavioral therapy. We also have 12-step facilitation. So 12-step facilitation, this includes things like Alcoholics Anonymous, Narcotics Anonymous, other faith-based groups. So pretty much here you have the sponsor-sponsee model, where you have a group of individuals who meet, nowadays on Zoom, sometimes in person. And then you have new members that look up to more experienced members. These more experienced members serve as leaders and sponsors. And the sponsor is pretty much an amateur therapist. So you could say a paraprofessional that helps the new member to identify what's causing them to drink, what's causing them to use, help to support them in moments of weakness when they're feeling tempted, help them to identify and achieve their goals. This is through the 12-step facilitation model. So we also have residential treatment. So this is like Rosecrance here in town. This is an inpatient facility where you will check yourself in. You will live in the recovery center. You'll receive probably some of these treatments right here. Also, there's a big reliance in AA and at Rosecrance. So they're probably going to be in the 12-step, some kind of 12-step program. And this is where you'll serve time. So classically, we've seen anywhere from 28 to 90-day treatment programs. So you've seen like the show Interventions, usually where you send somebody off to receive intensive recovery services. Then we have family therapy. So family therapy is important because usually when it comes to addiction, there is a system of disorder. There is a system of addiction that is operating within a family. So spouses, children can be affected by and contribute to substance use disorders. Now, not directly. It's not like, oh, it's a kid's fault, but you can be failing your kids. You could be abusing your kids by neglecting them. And, you'd have to involve the kids in the treatment. You have to involve, like, maybe even adult children. You have to involve the spouse in treatment to try to help everybody to heal from what's going on, but also to educate everybody about the disease, about the issue. So right over here, we have treatment outcomes. So these treatment outcomes are actually consistent across studies. So researchers have found that relapse is actually very common when it comes to treatment. So, a large, like a good number of people who leave treatment facilities will relapse at some point in time. Um, that doesn't mean that they'll never get sober again, but usually it's a process where there will be several periods of recovery and relapse in an individual's life before they either achieve abstinence or reach their harm reduction goals. Research also suggests that there is not a silver bullet treatment. So you can't say, well, CBT is the best treatment. You can't say 12-step models are the best treatment. Usually you want to have a system of recovery. So you want to have generally like several different methods that you're trying to use in order to try to help an individual. So improvements in health, social, and occupational functioning usually encompass a reduction in drug use. Now, once again, think about it. If I'm drinking too much, reducing my drinking can improve my health outcomes. It can improve my life. Same thing with drug usage. So some people say, everything in moderation, even moderation, right? So that's fine. That's one way to looking at it. So harm reduction helps people by reducing their usage and reducing the effects that occur. Now, the most positive long-term outcomes occur when there's going to be a high degree of coping resources, there's going to be social support, and low stress situations. So what does this mean? This means that with high degree of coping resources, if I get stressed and I know that drinking will reduce my stress, I need to find a new coping mechanism. So rather than going to the bottle, I need to go do some yoga, play some video games, call a friend, something like that. Do something else other than use drugs. Available social support. These are why 12-step models are usually recommended or preferred for individuals who are looking for long-term goals, because with 12-step models, you have that group aspect. You have people that you can talk to who can help you out along the way. And so this is very important for recovery outcomes. Also, low stress situation. So there's a reason why individuals from certain socioeconomic backgrounds might have a harder time recovering from addiction, because you leave treatment and then you go right back to your neighborhood, which is a high stress situation. Also, this is why individuals in toxic or abusive relationships have a hard time achieving their goals, because they leave treatment and then they go right back into their hostile home environment. So what you want to try to do, you want to try to help an individual surround themselves with supportive people in a low stress environment. This can be very hard, especially when we're talking about socioeconomic status. You can't just give somebody a bunch of money. From like a therapist perspective, you couldn't just say, well, here's 50 grand, move into a new neighborhood. So this is why you need larger types of reform and changes in the criminal justice system. We can talk about that in office hours or email. I have a lot of ideas about the way we treat addiction in this country. Number one, our largest mental health treatment facility or treatment location in America is going to be our criminal justice system. And we just take people and we shove them in there for no apparent reason. Oh, you're drunk, go to jail. Oh, you're an addict, go to jail. Oh, you had weed in your pocket, go to jail. It's kind of ridiculous when you think about it. There's a difference from drug cartels and that kind of violence and a desperate individual who is addicted to drugs and has a mental health issue and a lot of other issues. $50,000 a year to house somebody in a prison could be better spent on treatment. So, for example, I was talking about that example of giving somebody 50 grand. Could you imagine how things would be different if some poor person who was down on their luck, abused to drugs, rather than shoving them in jail, we put them in a treatment facility, help them out, and then after that $30,000 that we spent on their treatment, gave them $20,000 cash and put them back in society, rather than locking them up in jail where they just learn how to be better criminals. Anyways, that's outside of the purview of this course, but office hours email. All right, so there we go. That's the end of our lecture. So you'll notice here in this lecture, we did things a little bit differently. What I would encourage you to do is to go to the DSM-5, look at the diagnostic criteria, watch the videos that I've posted on the study page on Compass, those study videos. Watch this lecture, send me an email, come to office hours. All right, that's enough before I get myself in trouble. All right, peace.